Hello and welcome to Private Pregnancy UK's first ever webinar with special guest, renowned consultant Dr. Eskander of the Gynae Centre in London. Dr. Eskander has been practising since 1977 and today is one of the preeminent gynaecologists working in London. His practice, the Gynae Centre, has been a top clinic since 1999, offering his patients a one-stop gynaecological service for women. I'm your host Stephanie and I will be relaying questions that you, our readers, have submitted to Dr. Eskander to answer. Topics he covered will include well woman checks, abnormal smear and colposcopy, abnormal vaginal bleeding, sexual health, fertility problems, early pregnancy, miscarriage and gynaecological surgery. Remember, if you haven't already submitted a question, you still have time through our live broadcast. Now, without further ado, let's get started. Good afternoon, Dr. Eskander.
Good afternoon.
Tamara from Bristol asks, how often should I have a sexual health screen and what does it entail?
Yes, ideally, really, women should have a sexual health screen whenever they've had unprotected intercourse with a new partner. So before really she starts a new relationship, she has a sexual health screen. The most important is being really chlamydia and gonorrhea. Mm-hmm. So whenever she starts a relationship or changes relationships between partners.
Okay. Emily from Hereford asks, I sometimes notice vaginal bleeding for no apparent reason. Should I be concerned?
Yes, I think every woman should be concerned if she has abnormal bleeding outside her normal cycles. Now, the most important thing really to diagnose or to exclude is ectopic pregnancy or even pregnancy inside the uterus undergoing a miscarriage. So, simple pregnancy test at home is the first thing you do, and you can do that at home yourself. Now, if the bleeding does continue, or if it is particularly associated with pain, then you need to see a gynecologist. And the usual list of differential diagnoses one has to go through is, as you said, ectopic pregnancies, looking at the cervix to make sure there are no polyps, no erosions on the cervix, or what is called often ectropions, and then an ultrasound scan to exclude endometrial polyps, fibroids, retained tissue from a recent miscarriage. But the most common reason in younger people before the age of 40, it will be ovulatory problem. It's not unusual really for a woman to miss ovulation. And the cycle depends totally on ovulation to have a proper cycle of 28 or 35 days. So if ovulation doesn't happen, the hormones which build up and control the lining of the womb will be abnormal and they will bleed at any time. Sometimes cysts on the ovaries, simple cysts which secretes increased amount of hormones, estrogen, can cause abnormal bleeding. So quite often a pregnancy test and a transvaginal ultrasound scan will settle the diagnosis. Now, women after the age of 40 are at a slightly increased risk from having endometrial cancer and fibroids, of course. And these women in particular have to see the doctor rather more quickly to make sure that none of this exists.
Okay. Okay, Jane from Orford asks, does having an abortion reduce my risk of getting pregnant later on in life?
Not at all. The incidence of abortion worldwide among all races is about 20%. Which means every 5 pregnancy, nature just doesn't get it right and it will end up in a miscarriage. The most common reason is chromosome abnormalities, which is not compatible with life, and that will just stop the pregnancy very early, and so we can have a miscarriage and start all over again. So 1 miscarriage is pure chance of nature, 2 miscarriage, acceptable, 3 miscarriage, then there may be a recurrent reason, and that at that time, then we recommend the investigation. But having 1 miscarriage is not a problem, and it should be just looked at as a freak of nature.
What about if an actual abortion, will that affect?
An induced abortion?
Yeah.
A termination, no.
Okay.
Several studies has been made, and they found that abortion itself does not cause miscarriage, so it does not affect fertility,
okay,
providing there hasn't been any infection after abortion. That's why we prefer medical termination, which is associated with less instance of infection, and we're always required to do a chlamydia test, which quite often is the main reason for having infection following induced abortion.
Okay.
So do a chlamydia test before termination, opt for medical termination, which is associated with less infection.
Okay, great. Brianna from London asks, I've noticed a lump in my vagina area. What should I do?
Oh, hello, Rihanna. Rihanna, lumps are fairly common. Lumps happen because in this area in particular, because of obstruction of one of the glands which make up secretions. Now, glands are present all over the tissue, all over the body and underneath the skin. And in this area, you have a Bartholin's gland, which is right at the back of the vulva. You have sebaceous glands, which are oil glands, which are present all over the skin in the body. You have sweat glands, and you have glands of embryonic origin, which shouldn't be there, or just swellings really, which should have been obliterated. So once we make a diagnosis, then we decide how to deal with them. In general, a small gland does not require interference or any treatment, providing it's not causing any pain or is not infected. Once it becomes bigger, it can interfere with intercourse. And the best procedure for glands like labial cysts or swellings like labial cysts or Bartholin's glands is to open it up and stitch it around the skin, and we call that marsupialization, which basically creates a very small opening which remains permanent and drains the gland permanently, but can get obstructed and can recur in about 20%. Now, smaller glands like sebaceous cysts or sweat gland cysts or hair follicles, those are commonly removed if they're not terribly infected. But if there is an abscess there, the best thing is just to open it up and drain it.
Okay. Zoe from Oxford asks, I received the HPV vaccination as a teen, but I now have been diagnosed with HPV. How is this possible, and should I be concerned?
Oh, thank you, Zoe. Now, HPV, the current HPV vaccines that we have only protects against 4 types of HPV virus. That's virus 6 and 11, commonly responsible for vaginal warts or vulval warts, and 16 and 18, the commonest and the highest risk of HPV virus, which can lead to precancerous cells. The vaccine only works to protect against these viruses, but there are some evidence to suggest that it may provide some immunity against some other 14 or 15 viruses. Okay. But the fact is, if you get infected with a virus which is not present in that vaccine, there is a still high risk that you could actually end up having an HPV infection.
Okay, great. Jordana from London asks, I've been struggling with side effects of the menopause. How can hormone replacement therapy help me, and are there any risks associated with this?
Hi Jordana, and thank you very much for that question. The menopause happens really because of cessation of hormones, and the most important hormone is the estrogen hormone. Lack of estrogen will result in hot flashes, night sweats, and all the symptoms associated with the menopause, like dry vagina as well. Now, until recently, doctors used to prescribe HRT and hormone replacement therapy quite freely to all women, and with benefits. There has been some recent studies. The most famous ones are the ones in the state, which were stopped early because they found an increased risk of strokes and breast cancer in women taking HRT. Now, this is called the Million Women Study, or the Women Health Initiative Study, something like that. However, in recent years, doctors have increasingly gone back to prescribe hormone replacements because the benefit seems to outweigh these small risks. One has to remember that the risks associated with hormone replacement is really pretty small. Now the benefits are enormous. Hormone replacements will relieve 90% of hot flushes, night sweats, dryness of the vagina, and has been found to have positive and beneficial effect on the heart. So on the whole, if you are suffering from menopausal symptoms at or near the menopause, it is better to take HRT. The risks is really small, and the risk of breast cancer is associated with combined therapy, and it has been found to be mainly due to the progesterone and not the estrogen. So if the uterus has been out, you don't need to take progesterone, you can just take estrogen replacements. Best thing is to go discuss it with your doctor and weigh the benefits against the small risks.
Okay. Ariana from Surrey asks, how soon can I do a pregnancy test?
Yes. The pregnancy takes place in the outer part of the tube in the abdomen. Mm-hmm. So that's where the sperm will meet the egg in the outer part of the tube. Now once they unite together, it travels back to the uterus and takes about 7 to 10 days before it implants. That means there is no contact between the pregnancy and the mother for a period of 10 to 12 days. Mm-hmm. So the earliest time a hormone will be secreted into the mom's circulation will be 12 days after ovulation and fertilization. Mm-hmm. So before 12 days, it is not possible to know whether one is pregnant or not with the most sensitive test. Between 12 to 14 days, the tests that we have are very sensitive, and they will, on the whole, pick up a pregnancy. So no need to do one before 12 days.
Okay. Leah from Manchester asks, how can I tell if I'm ovulating?
Yes. Ovulation happens because of a hormone secreted from the pituitary gland, the gland which is situated between the eyes and behind the nose, and it secretes a hormone called luteinizing hormone, or LH. Now the LH secretion is usually very low in the first half of the cycle until the egg matures, reaches a certain size, usually of about 20 millimeter, when it will then secrete hormones which will trigger the LH secretion. The LH will rise for 12 hours only, and the LH will be responsible for triggering ovulation. Now there are ovulation tests in the market which will pick up the LH surge. So if you were to do an ovulation test just before ovulation, twice a day, let's say from day 11 to day 12, you will pick up the LH surge when the test will become positive. Now the most important thing to remember is that ovulation does not happen at the time of a positive ovulation test. It takes 36 to 40 hours for actually the egg to swell up, or the follicle to swell up and release the egg. So the best time to have intimate relationship will be 36 to 40 hours after a positive ovulation test.
Okay. And are there any physical signs that I can look for, that they can look for without, instead of using an ovulation test?
Yes. Women used for many years. Women have realized that the mucus secreted from the vagina before ovulation can stretch up, and it's very mucoid and stretchable. Mm-hmm. Now, the moment that mucus changes to a thick, non-stretchable mucus, it means that ovulation had already occurred, perhaps in the last 24 hours. Okay. So it's a sign that ovulation had happened, and since the egg only survives for about 24 hours, you may actually miss a good time to get pregnant. So okay. I still recommend ovulation tests.
Okay. Rena from Blackpool asks, do I need cervical screening test if I've had a hysterectomy?
Well, if you've had a total hysterectomy, which means the cervix was removed, no. But some doctors will do subtotal, which means the cervix will be left behind and they will recommend to do a smear test because it's just a cervix like any other cervix. But the good news is that usually if people have had hysterectomy in the mid or late 40s and have the cervix left behind, they only need to do the cervical smears every 5 years, and quite often they can stop after 70, 72 years of age.
Okay. Henrietta from London asks, I have constant burning in my vagina. What should I do?
Oh, I'm sorry to hear that, Henrietta. Now, unfortunately, whenever women have burning in the vagina, they always relate it to thrush infection, which is not the case. It's true most of the time, but thrush infection always manifests itself by vaginal irritation, not necessarily burning, and a vaginal discharge which looks like curdy milk or yogurt. So that's a thrush infection. It will be safe to pick up something over the counter. But recurrent thrush infection after treatment, that has to be looked at by a doctor, particularly if it's associated with burning. Now, there are many causes. It could be that they have a skin fungal infection rather than vaginal thrush. It could be that they have a condition called vestibulovulvodynia. Now, this is a condition which we do not understand exactly the cause of it. It is associated with some inflammation if we were to take a biopsy, but we don't find any responsible bacteria or virus infection, and it's not easy to treat. And the only treatment we give at the moment is local cortisone treatment or local Botox injection, and that seems to offer relief in about 80% of people.
Okay.
Now, a word of caution: burning and irritation in the vagina in women over the age of 50, i.e. in the menopause, those can be due to conditions like lichen planus or lichen sclerosis, and we need to biopsy it to confirm it, and the treatment often is high or strong doses of cortisones.
Okay.
But some of them have to be washed because it could be precancerous as well.
Okay. Simone from London asks, when will my periods start again after giving birth?
Yes. If you are breastfeeding, Simone, then the periods will not come for an 85% of people until you stop breastfeeding. So there are still 15% who will have periods while they are breastfeeding. Now, if you're not breastfeeding, then you should expect your period anytime between 6 to 12 weeks after delivery.
Okay. Juliana from Gloucestershire asks, I find myself in a lot of pain during sexual intercourse. What could be causing this?
Oh, I'm sorry to hear that, Joanna. Having pain during intimate relation can obviously affect the relationship, and if it is not after a recent delivery, then I think you need really to be examined to find out the site of the pain. Now, the pain can be divided into pain outside the vagina, so in other words, just at the entrance, and that could be due to local causes, a small cyst, vaginal warts at the entrance, and this can be easily treated. And then we have pain at deep penetration. The most important thing really to make sure that you don't have is endometriosis. I'm just going to explain quickly about endometriosis. The lining of the womb is called endometrium. So that's the inner cells of the womb, endometrium in Latin. Now, the lining of the womb is very special because every month it grows in response to hormones secreted by the follicles and the eggs and hormone estrogen, and it prepares really for the baby to implant. And then if there is no pregnancy, that lining will drop out, break down, and comes out as menstruation. Now, if these cells were present elsewhere in the body, anywhere, they will also respond to the hormones exactly in the same way. Now, if they were under a particular surface, the blood of menstruation will not be able to come out as it does in case of the uterus, but will be entrapped under the surface of that tissue and create a blood clot. Month after month, it will become a blood nodule. If it's on the ovary, a blood cyst, and we call that endometrioma. If it is outside the ovary, we call that endometriosis. Now, the body will not like abnormal tissue and abnormal blood inside the cavity, and will try to go and fight it with all defense mechanisms and create a foreign body reaction, which results in scar tissues, irritation of the nerves, and pain. So the commonest place really for this migration of these endometrial cells, which happens usually during the period, is in fact in the back of the uterus. It's the most dependent area where the blood will just fall from the tube, drop in the back of the uterus. Now, in most people, the endometrial cells, these abnormal endometrial cells, will not be able to get hold and multiply. But in some people, they're more vulnerable than others. They will actually implant like a seed, multiply, keep bleeding every month, and after several months or several years will cause symptoms typical of endometriosis. And that is pain, which happens with the period or just before the period, lasts throughout the period, and beyond the period as well. And when one examines, you will feel that there is an associated tenderness just by touching the back of the uterus or the side of the ovaries, and an ultrasound scan may show this tissue, may show this tissue and show tenderness, but the only way to confirm it really is by laparoscopy, by putting a camera inside the tummy and seeing it, and then can be treated usually by excision and cautery.
Okay, great. Okay, a question from Regia that's just come in. I had a grade 2 vaginal wall tear internally. How long will it take to heal completely? Also, after my pregnancy, I have anal skin tags. Is there any medications to shrink it?
Yes, vaginal warts are really due to human papillomavirus infection. They may regress spontaneously by body immunity, but the quickest way to treat them is by local medication, like Warticone or Aldara cream, or by removing them by heat or by freezing them by cold cautery, like cryocautery, what we call cryocautery. Anal skin tags are just excess skin, usually due to constipation and constant pushing in this area. They can easily be removed by a minor operation under local anesthesia, which we can do here at the Gynae Centre.
Okay. Nicola from Liverpool asks, my partner and I are trying to become pregnant but have not so far. At what point should we seek fertility treatment?
Oh, thank you, Nicola, for that question. That's people always ask, yes, how long does it take to make a baby? And there are several studies which have shown that it takes an average of 9 months for a great deal of number of people. I can't remember the figure exactly, but about 80% of people will achieve conception within about 9 months. There are a smaller number of people might take longer, 18 months and 2 years and up to 3 years without help. But the general advice is that if nothing happens after 9 months, go and see your doctor. The simplest test to do to start with is your husband's semen analysis, and an ultrasound scan to your ovaries, to the uterus, to make sure there's nothing like fibroids or lack or too many follicles on the ovaries. That's the simplest one.
Okay. Ariana from Bristol asks, what does a well woman check consist of, and do I really need to have one?
Yes. Funny enough, actually, in the UK, we do not do a regular well woman check. And I get people from all over the world who find it very strange, because in the States and in Europe and in most countries, women are used to go and see their gynecologist at least once a year. Now, the pressure on the NHS really is enormous here, and does not allow really for space for anyone to have just regular checkup. And we have to remember as well, we have to ask the question, does well woman screen have any proven value? There are really no studies to show that if you do a regular checkup, it will prevent particular diseases except for the cervical smear, and that's why it's adopted by the NHS. However, that doesn't mean that you don't have to do it. You could have a checkup once a year, and I think it's a good habit as well, and that will involve looking at the general parameters of the blood, like to make sure you're not anemic. Women bleed every month after all, and they lose a certain amount of blood, so it's a good habit to do a regular blood check once a year, and check the lipid profile, which we do here, check the cholesterol, the bad cholesterol, the good cholesterol. We also do a full history to discuss the contraception. We do a smear test if it wasn't done in the past 3 years. We do an ultrasound scan to make sure there are fibroids or absent, to exclude the absence of fibroids. At least it's just good knowledge to know if one has a problem or not. The downside of screening is that one may discover cysts which may not progress into any abnormality and disappear on their own, and it might result of unusual interference. But still, I would recommend a screen, and we have at the Gynae Centre devised special screens for women. So under the age of 40, we do a blood profile, including a cholesterol and lipid profile, an ultrasound scan, as well as breast examination, history, and full examination. Now, if you were after 40, we like you to have an ovarian screen by looking at the ovaries by ultrasound, and then doing a blood test called CA125, which goes up in case of ovarian cancer. Again, you have to bear in mind a positive test may not necessarily mean that you have cancer, and one has to really translate it in the context of the history and everything. What else? After the menopause, obviously, to discuss hormone replacement and to see if it's necessary. And also breast screen in this country starts really at the age of 45, 47.
Emma from Nottingham asks, does an abnormal smear result mean that I have cancer?
No. Emma, you have to remember, we do smear tests regularly for one reason only, to prevent cancer, not to diagnose cancer. Cancer usually presents itself really with abnormal bleeding or bleeding after intercourse. And since we have introduced the smear test and the program of screening, the incidence of cancer has dropped dramatically. We do smear tests to prevent cancer by picking up abnormal cells before cancer develops, often years before it develops. The most common time, or the most important time to screen, is between the age of 25 to 30, because abnormal smear at this time would mean that persistence of the virus, and which may progress into cervical cancer. Now, so a smear test will show nuclear abnormality in the cells, and they will test it now automatically for HPV, and if the virus is present, you will be recommended a colposcopy. Now, a colposcopy will tell us whether there is a serious abnormality which may progress or a mild abnormality which may regress. Worst case scenario, serious abnormality, abnormal cells, we just destroy it by one mean or another, often by a loop excision, where we just remove a small cone from the cervix, or by destroying the cells by means of diathermy and just burn it out. One way or another, 90% of people, it will never come back again.
Okay. Janet from Winchester asks, how is a colposcopy different from a smear test?
Yes, so both of the smear test is a wonderful test because it can be done simply by nurses, by doctor, and it's just taking a sample of mucus which contains the cells from the cervix. Colposcopy can only be done by trained health professional and involves doing a microscopy in addition to applying acetic acid to the cervix. Colposcopy will show severe abnormality, and it is associated with biopsy. So in other words, we can't do colposcopy alone. So colposcopy will allow you to see abnormal areas, and once one sees abnormal areas, we pick up a small biopsy often painless under local anesthetics, and the lab will tell us from the biopsy more accurately than the smear test whether the abnormality is mild or severe. So a smear test look at individual cells, whereas a colposcopy allow you to look at a sheet of tissue after taking the biopsy.
Okay. Francesca from London asks, is it normal to bleed after sex?
No. Francesca, you have to remember that everybody has sex and everybody does not have bleeding. So abnormal bleeding after sex is, bleeding after sex is unusual and should be regarded as abnormal. Now, sex comes, during sex, the husband or the partner comes in contact with the vagina and the neck of the womb only. So if there is something fleshy, like a polyp is just a small benign growth which happens because of obstruction of the glands, so that could bleed, and that's simple. The polyp can just be removed during the course of the examination. Chlamydia infection is very important, especially in young people between the age of 20 to 30. 1 in 10 people of that age group, especially the younger group, have chlamydia infection. Chlamydia causes inflammation, and inflammation will cause bleeding. So a sexual health test is very important as well. Now the third category and most important ones is that if there is cell abnormalities. Now cell abnormality, I'm talking about precancerous cell abnormality. That will make the cell fragile and they will bleed very easily. So the normal course of action is to have the cervix examined, make sure there is no inflammation, make sure there is no chlamydia, exclude a polyp, and if none of those is present, a smear test to make sure there are no abnormal cells. Now, if the bleeding is repeated and in the absence of any abnormality, then we prefer to do a colposcopy to make sure that we're not missing cell abnormality not picked up by the smear test.
Deborah from York asks, if I use a condom, do I still have to worry about STIs?
Very good question, Deborah. On the whole, condoms are safe and they protect against sexually transmitted disease. But just remember, they can have little holes. Seminal fluids can leak through the holes, and then as well sexually transmitted disease such as chlamydia and gonorrhea. The chance is very rare. I don't think you need to worry about it.
Okay. Miranda from Sheffield asks, how often should I have STI tests?
Thank you, Miranda. I think before you embark on any new relationship, you should have a clean bill of health. The most common sexually transmitted diseases among young people between 20 to 30 years of age is chlamydia and gonorrhea. Chlamydia affects about 10%, that's 1 in 10 of young people, and 5% gonorrhea, that's 1 in 20 of young people. Those are the most common ones. There are less common ones, and if you wanted a clean bill of health or a certificate just to show to your boyfriend, then you can also include syphilis, HIV, as well as hepatitis B and hepatitis C. Just remember that HIV and the hepatitis B and C may not show in the blood until about 2 to 3 months after exposure.
Lily from Gloucester asks, is there a particular age where fertility declines drastically?
Yes. Funny enough, fertility declines every month from the moment we are born. So at the time of adultship, we have the highest number. I can't remember the figure, but we probably have 500,000 eggs on the ovaries, on each ovary at the time of reaching puberty. And every month we lose some of these follicles, but still a lot of it is left. And the decline is steady and slow right until the age of 30. Now, after 30, that decline starts to increase slightly more, and the ovaries lose a lot of follicles, but still it had good reserves until 35. From 35, it decreases still a little bit faster until 38. Now, from 38 and 40, the decline is worst. And therefore, really, we advise women to make sure that they complete their family or at least start their family before 35, because the decline can be faster and faster from 35 onwards.
Okay. Amy from Exeter asks, what are the most important scans to have during early pregnancy?
The most important scan is the Down syndrome screen scan at 12 weeks. Although nowadays we have a new test called Harmony test, which can be done from 10 weeks. Now this is just simply a blood test, but it does require an ultrasound to confirm the dates at the time. So soon we will be changing to the 10 weeks to do a dating scan. But I'm going to go back again and recommend strongly the 12-week scan, because it's not just only important for diagnosis of Down syndrome. It is important to pick up a lot of abnormality like anencephaly, large bladders and bladder ureteric obstructions, or urethral obstruction, urethral valve obstructions as well. So there are lots of abnormalities which we can pick up still at 12 weeks, and will direct our research into finding out whether the baby is abnormal in particular area by that ultrasound. So if I have to have one scan, the most important is 12 weeks. Of course, we can do scans at 6 weeks and 7 weeks and 8 weeks for viability and really for people to be reassured. But don't miss out on the 12-week scan.
Sophia from Derby asks, I've had several miscarriages. What does this mean for my current pregnancy?
Sophia, I'm not sure what several means. As I alluded earlier on, 1 to 2 miscarriage is not unusual, and usually is due to chromosome abnormality and does not mean that it's going to come back again. Now, if you have 3 miscarriages, there is about 2% of population who will have 3 miscarriages. And there are reasons for it which could be recurrent. And at that time, you should be really looking at reasons within the uterus, such as infection or an abnormality, reasons within the parents, such as chromosome abnormalities. And there are also other 2 important categories which we examine for here is thrombophilia. Thrombophilia means basically that due to a blood clotting abnormality, some people are prone to have clots within the blood vessels, especially the small blood vessels, spontaneously. Now the theory is that these people, if they develop clots and obstruct the blood vessels in the placenta in the early part during implantation, it will compromise the blood supply and lead to early death and miscarriage. And those people will benefit certainly from anticoagulants, blood thinning injections, which will allow the blood to flow within the placenta. And for example, the most common is the anti-cardiolipin, antiphospholipid syndrome. So we always test for this, for thrombophilia, and do a thrombophilia screen. Now there is another category of patients who might have immune issues or immune problems. Now these people might have signs of headache, rheumatic pain, and they might have a heightened immune system which will not accept or will not allow early development of the fetus. So these people have an increased number of natural killer cells in their blood, or even locally in the uterus. So we like to test for them. These tests are still controversial, but they are done, and we do them, and they are sent to a major center in Chicago, Rosalind Franklin, and we've had very good success if we can lower the natural killer cells by the use of intralipids or IVIG. Mm-hmm. So it's worth going through the simple ones first before we progress into natural killers and thrombophilia screens. So if you've had 3 miscarriages, it's worth going to a doctor and ask for these tests.
Okay. Sarah from London asks, is there anything I can do to prevent a miscarriage?
Yes. If there was a reason that we find, such as a fibroid within the uterus, inside the uterine cavity, a polyp inside the uterine cavity, a septum inside the uterine cavity, and we remove it, yes, it will stop you having another miscarriage. If there was evidence of thrombophilia, yes, Clexane or anticoagulants taken throughout pregnancy will reduce the chance of miscarriage. If there was high level of NK cells, which can be reduced by intralipid or IVIG, yes, there are evidence that it will increase the chance of having a live pregnancy. These are all well established in the past 10 years only. So yes, providing we find the reason. There will be a small group of people whom we do not find a reason at all, and it remains to be unexplained.
Okay. Rebecca from Leeds asks, when is the earliest I can find out the sex of my baby?
Yes. In our clinic, and particularly with myself, I have long experience, so well-established gynecologists probably can do the same, but I have long experience and interest to look at the baby's sex as early as 12 weeks. And in our clinic, we are able to see with great degree of certainty, close to 100%, the gender of the baby as early as 12 weeks. Most other clinics cannot see it until about 14 weeks or so. It's usually down to experience and down to the machines available. But we are happy to make 100% diagnosis from 12 weeks onward.
Okay, great. And the last question comes from Mindy from Jersey, and she asks, what kind of results could I expect from vaginoplasty?
Yes, vaginoplasty should only be done if the woman feels very loose, particularly after childbirth and after she completed the childbirth. It's natural, the vagina has been distended, she probably had weak muscles as well, and she would like really a cosmetic procedure to get the vagina back to how it was before, and also to tighten the muscles in this area and remove any loose tissues. That is the ideal candidate vaginoplasty. It is not a substitute for pelvic floor exercises. So if somebody comes in younger, I've had somebody yesterday, she was 23, and she thought that her relationship is going to break down because the partner complained that she's very loose and he can't feel her. These people have absolutely normal anatomy, normal muscles, and all what they need to do is just to exercise their pelvic floor muscles daily. The same muscle which controls the urine, if they can just contract that 10 times in 1 hour, 10 times a day, then the muscle will become strong within 6 months and she does not need vaginoplasty. But the results to expect after a loose vagina, after childbirth, really are pretty good because we remove the loose tissue and we tighten up the muscles together.
Thank you again, Dr. Eskander, and I hope you enjoyed our webinar from the Gynae Centre, and join us again in a month or so's time for the next one.